Well, I think it's safe for us to get things started, and if more folks join us during the presentation, that's perfectly fine. But thank you, everyone, for joining us for today's webinar on managing joint pain in the hip and knee. My name is Megan Noe. I'm with MU Healthcare, and I will be here today to make sure you get all of your questions answered. So if you have questions that come up, you can submit those. You should see a Q&A button at the bottom of your screen, and if you click on that, you'll be able to type your questions in, and then we'll see those and we'll get to those at the end of the presentation, so stick around till the end. But before we start here, we actually have a poll question for everyone. So in just a moment here, you should see a poll question pop up on your screen. You can feel free to choose the answer that most applies to you. And this will help us just tailor the presentation a little bit more to our audience. So I will be quiet for just a moment and let you read those questions there. All right, well, hopefully most of you had a chance to answer there. And with that, it is my pleasure to introduce our expert who will be leading today's webinar. We have Dr. James Keeney. He is the Director of Adult Hip and Knee Reconstruction Service at MU Healthcare's Missouri Orthopedic Institute. You can see the results of the poll there. So we've had some good responses and looking forward to learning more today. So with that, I will turn things over to Dr. Keeney.
Thank you and good morning. Thank you, Megan, and good morning, everybody. So you saw these two questions, and they're questions about whether you've had treatment for joint pain, and there are several of you who have not yet, and there are many of you that don't know much about joint replacement. That's okay too. It's not the only treatment that we certainly provide to our patients, and but it's something that it's a part of what I do as a core part of my surgical practice. So we do end up touching base on that. But thanks for being here. I'm gonna go ahead and roll the first slide, man, if that's all right. This is who I am. I'm the head of the hip and knee service here at the University of Missouri and Missouri Healthcare. We practice at the Missouri Orthopedic Institute, which is a freestanding orthopedic hospital here in Columbia, Missouri. My background, I went to the Air Force Academy and graduated from there about 35 years ago. And then did my orthopedic training at Washington University School of Medicine. Spent about 12 years in the military, and I've been in practice in joint replacement and hip and knee surgery for about 17 years now. So today we're going to talk about causes of joint pain and the way that we approach treatment for it. We'll talk a little bit about what we do in our practice in joint replacement surgery and how we innovate or we introduce innovation in our care for our patients, and kind of wrap up at the end. Look forward to having questions as you have them. So what causes hip and knee pain? There's a variety of things that people may experience that ranges everything from injuries around the muscles and the tendons. So the muscles are the things that power us. Tendons are the point of attachment of a muscle into the bone. Ligaments are the stabilizing structures around our joints, and it's when we injure those are called springs. And then when we can have injuries to the bone around our hip or around the thigh or around the shin bone, that can all contribute to things. Sometimes we see things are called stress reactions or stress fractures that can come from a sudden change in activity or a transition of overdoing things can cause that. And then we see a lot of patients as time goes on who have some aging of their joints, and that can start in our 30s and 40s, but we most commonly see that as we get to be in our 60s and 70s. So talking about arthritis, what is that? Arthritis is a degeneration of joint cartilage. And it starts mostly in our middle years and onward. It's been called degenerative joint disease as well, and we thought of as kind of a wear and tear process. As we understand things, there's some elements of this that are related to the structure of the joint that contribute to it developing arthritis over time. It affects our hip and our knee joints commonly because while we can take our weight off of other parts of our body and change the way we use them, we can't avoid using our joints and our legs. And so we're more likely to feel those things if we start getting aging and arthritis. So this is an X-ray that we've seen. If you think about that, this is what our X-rays will typically look like on that left screen, which is a normal joint space. And you can see how wide that is. But over time, when you have arthritis, that joint space will thin. And then what we also can see are these other things like bone spurs around the joint. And if you notice the difference on the X-ray, the bone density looks like it's more white on the X-ray on that right side. That's what happens when the cartilage is gone. The bone ends up seeing more forces, and that makes the bone respond with more bone being laid down. Sometimes that's also associated with an inflammation process that we see in the bone. And while we don't see that on an X-ray, if somebody has an MRI scan, we could see that that inflammation was present. For that X-ray on the right, we don't need to get an MRI because we already have a diagnosis, but we do know there's an inflammation process that occurs as the cartilage goes away. There are a variety of non-surgical treatments that we try to help our patients with before we ever talk about any kind of surgery. I get to say that I could always lose a few pounds. I weigh probably about 15 to 20 pounds more than I did 20 years ago, and it'd be nice if I kind of didn't carry as much. The effect of our weight is about 6 to 9 times the weight that we carry going across our joints. And so every pound that we lose is actually about 6 pounds less across the joint. Engaging exercise is important to keep our muscles strong, keep the tissue balanced around our joints. And so this is an important part of our recovery, and also a recovery from injury, and also recovery and management and maintenance for our health. There are a variety of medications that we use to help patients. Most of you are familiar with them, whether those are over-the-counter anti-inflammatory medications. We do use acetaminophen or Tylenol-based products for helping pain. For a long time, we've used much stronger medications and have seen some effects of those things. And you guys are probably familiar with the opioid crisis that kind of occurred. For some of us, it's pain medication that was needed, and for other people, it was a change in the pain response, so things started hurting more. We do cautiously use those. We found that some patients that have taken tramadol don't seem to have problems with it, but some of the stronger medications can cause problems. But we do want to try to manage that with kind of as an as-needed approach to medication for anti-inflammatory medicines, if you can take that. When those things are not working, we kind of get into the next phase of things, which are injections of medicine directly into the joint. And there are about 4 different things that we can use for injections. Those include things like steroid medicines, which decrease the inflammation directly. And there are another type of injection you guys may be familiar with called a visco supplement, or a gel type injection that's put into the joint. Those are relatives of a substance called hyaluronic acid that's in our joints naturally. And what it's trying to do is take our joints where with arthritis, the joint fluid becomes more water-like, and trying to restore it back to where the fluid would have been like with a healthy joint. And those things can be helpful. There are a couple more recent types of injections that have come out over the past 10 years or so, and those are called biologic agents. Those are things like platelet-rich plasma, which is a spinning down of our blood and then injecting the growth factors in around the joint, and that can be helpful. There are some treatments called stem cell therapies, and those things we don't do here, but some patients have gone other places and had them done. And those can be helpful as well. We don't know whether they're rebuilding cartilage or if they're just helping the inflammation response. So it's going to take a little while before we fully understand what those are doing. We already talked about this before, is when we put weight on our joints, there's somewhere between, I said 6 pounds, it's actually about 6 pounds, but it could be anywhere from 4 to 9, depending on the intensity of exercise. So it's important for us to try to modify our weight if we can. And then these are some examples of things that we can do for exercise, whether we do them at home or we do fitness classes. And water therapy is a really particularly good thing to do because it takes the stresses of our joints off of our joints, and that can be helpful. And formally working with a physical therapist, I think, can be very beneficial because they see things in our body mechanics and ways that we can do things that will help make our pain better. There are also currently therapists are doing a lot more hands-on and manual therapies that can actually help to alleviate pain as you're experiencing it today. And then we talked about some of these earlier. These are a variety of different things. I didn't talk about dietary supplements initially, but those can be helpful. They certainly are less likely to cause physical harm to the body. So why they may not always work, they're probably worth trying for a lot of us because they can help alleviate pain without causing risk of harm. And then, so these are all those things we talked about. I think that the studies are supporting that platelet-rich plasma works very well. The hard part we've had is that the insurance companies haven't recognized this. And so these are things that our patients end up having to pay for, but they can be effective. But all these can be used for treatment. Okay, and I'm going to let this roll through the slides and talk about on this face sheet. So let's go on for the next slide. So these are the treatment options for surgery. Some of you may be familiar with an arthroscopy. This is the least invasive type of surgery that we do. This is where a small camera is placed into the joint. Very small incisions are used. The purpose of this is to clean up damaged tissue or to repair damaged tissue and allow the body to recover without a major open surgery. And this has really changed things. When I think about a number of years ago, 40 or 50 years ago, if somebody had a meniscus tear, they would do an open surgery. They would remove the entire meniscus. And people would get arthritis over the course of 5 to 10 years sometimes. So by only removing the damaged part of the meniscus, that surgery can be done, and it really keeps the knee healthy and doesn't cause it to wear down nearly as fast. There are surgeries that are done typically for patients who are 45 years of age and younger, when the joint forces are being put across the leg because of the alignment of the leg. And these are surgeries that are done to reorient the joint, to take pressure off a damaged part and shift it over to an area that's healthy. And we can use these around hips and knees. Again, this is normally for people that are 45 or 50 years of age and younger. And then joint replacement surgery sometimes is done in younger patients, but usually for patients who are 50 or 60 and over. And this is essentially an artificial joint. That the purpose of that is to remove really severely damaged cartilage and to replace it with prosthetic component parts that will replicate the function of a normal joint, not perfectly, but to make it close to it, and to improve joint mobility and also improve pain substantially. We've looked at our data on our patients who have had surgery done, and we know that patients are between 90 and 95% of them experience significant pain improvement and function and satisfaction with the surgery. A little bit better in hips than in knees, but still very good. In a total knee replacement, what we're doing is we're replacing the damaged bone and cartilage with metal and plastic parts. So that this artist drawing here, the metal are the gray parts, and then the blue components are the plastic parts that go in. So the parts are attached to the bone. They can either do that with the implant being glued onto the implant, which was a traditional approach, and that's a cement that you see here, or they can be directly attached to the bone with a surface that the bone will grow into. There is a specific type of procedure called a partial replacement. I guess that's a quick way of saying only there's 3 parts of the knee. So if you have damage really to just one part of the knee, you can have a complete replacement of that one part, and that's called a partial replacement. So it's not really partially done, but it's not treating the undamaged part of the knee. So these are kind of different parts that you can see. And so the ones on that left side, those are partial replacement parts. They're smaller components, but they're only treating that one part of the knee. And then we have a variety of things. So these total replacements, that's an implant on the thigh bone and the shin bone with a piece of plastic between them. And then if you look on the far right, these are 2 versions of an implant that have something unique about them. The one on the top is a patient-specific implant. It's designed with 2 separate inserts of different thickness, so that the thigh bone implant is put in to match your anatomy, and then you make up the difference on where the thickness of the inserts are to balance the ligaments around the knee by a different shape of them on each side. The one on the bottom is that black coating is a allergy reduced implant, and the design is to not have small amounts of nickel that are in the implants to potentially get into the joint and to affect inflammation in some people who might be sensitive. Most people, even if you have an allergy to nickel, wouldn't respond to a typical implant, but sometimes we use these just to make sure that we don't have a concern for a patient. And then hip replacements, these are the parts that we have there today. Hip replacements are mostly being done with a titanium component put in the hip socket and a titanium component put into the thigh bone. And then a ceramic ball used for the femoral head, and something called highly cross-linked plastic being used for the hip socket. If you recall a few years back, you might have been seeing things on late night TV that were saying, if you had a hip replacement put in by this company or that company, those concerns were based off of trying to use a metal on a metal design hip. And those came about when plastic materials were having trouble back in the 1990s, and they were being used as a substitute, and it didn't work to be better than what we're using today. So metal parts in the thigh bone and the hip socket, and then a combination of ceramic and plastics, what we use in the hip. And this is a very durable solution, probably going to last for 20 to 35 years for patients. And there are a variety of techniques that have changed over time that's trying to help the process of recovery from hip replacement surgery. That includes smaller incisions and less direct damage to the muscles when we do the procedure. So this is a slide that's going to show 3 different ways that you can get into the hip joint. What I will say is that the lines that you're seeing there are a little bit different in size because they can all be done with an incision that's close to the same size as what you see in C. The thing that's going to make the incision bigger or smaller is the amount of space that's needed to safely work into the hip to preserve and protect the vital structures around the joint. But each of these approaches is very successful and can help patients recover very well. And these were the three types of things where I talked a little bit. If you look at the far right, that's a metal on metal implant. And those are the kind of ones, implants that we don't use anymore. The one on the very far left is a special implant for people who have a potential risk of hip stability. And so it has a large plastic ball that's placed against a metal liner that's placed in the shell, so it allows more range of motion potentially. What we don't know exactly is whether that's going to contribute to more plastic wear in the hip. So we don't use these for everybody, but we use them for people who may engage in higher amounts of motion for the hip to be a little bit more protective against hip dislocation. That implant that's in the middle is uniquely used and not commonly used anymore, and it's a ceramic on ceramic bearing. I used this recently for someone who had a plastic allergy, and it's an alternative that can be used. That's a hard on hard bearing, so there is some risk of fracture of that device, and so we use it fairly selectively. And that's what you see on the X's. So there's been some real changes in hip replacement and knee replacement surgery over the past 10 years. And traditionally, a hip replacement or knee replacement would be a couple of days in the hospital. And now most patients are going home within 24 hours. And I think that that's been made possible from a variety of things. One is we try to help our patients get a little stronger going into the surgery, and that helps the recovery process. We've also done some things with what's called multimodal, or using several different types of medications to help, as well as changing the way that we do anesthesia, and then fairly quickly engaging our patients with physical therapy to work together. So if patients have surgery in the morning, they usually will work with physical therapy in that afternoon and evening. And our patients who finish surgery later in the day, we'll end up seeing patients that night and the next morning. So we get a couple of different sessions in. And that's just to make sure that our patients feel like they're recovering well and they feel comfortable with going home. I will say that none of us are as comfortable going home the day after surgery as we might be in 3 to 5 days. But we've found that medically our patients don't need to stay in the hospital as long as they used to. So this is really feasible and going. How do we make sure that things go well? I think there's a number of things we do. One is trying to prevent infection, and we've been very effective at that. Our infection rates here in healthy patients is about 0.3%. And so I think that there's a variety of things. One is we have this skin cleaner called chlorhexidine that we have our patients use to clean their skin for about 3 or 4 days before surgery. We do the surgery with very clean technique. It's important that we watch our diet and we avoid things that might boost our blood sugar level. If we have patients who have diabetes, we have a diabetes specialist who sees them while they're in the hospital. We use 2 different antibiotics used together that help to boost our body's ability to fight off infection. And then after surgery, we really minimize the amount of dressing changes and times that we have potential contact. So we have dressings that are waterproof, and we can wear them for generally a week or 2 at a time before they have to be changed. And so these are the things, and just make sure we're not changing these very often. I think these are we've already mentioned, very good ways for us to prevent infection and also get our recovery. So, and this is most of our patients will go home with one of these cold therapy units. We find that that's very good. Ice and cold therapy is good at decreasing inflammation chemicals. Working with movement, although it hurts at first, what we find is as people get involved with movement of their joint, it does decrease pain. And we're trying to limit the amount of time that people are taking stronger pain medications because the body gets used to them after about a week or a week and a half. And so the sooner you can taper down on those, then the less likely you'll have pain that goes on for a long term. So if you do have a surgery with us, we'll get you up and get you moving very quickly. Most of our patients are walking between 75 and 150 feet after their surgical procedure. We do put a hip in or a knee in that's stable and well balanced to make sure that it allows your support to get up and get moving quickly. And we generally will encourage our patients to go work with physical therapy a couple times a week for a period of 4 to 6 weeks after surgery. And for our knee replacements, we see back at 3 weeks and 6 weeks in the office. For our hip replacement patients, we see folks back at 6 weeks. And then definitely for 1 year and 5 year surveillance. And then anybody having any concerns at 3 months or so, we still would like to see and just make sure we have a plan of recovery for you that's working well. After our patients have surgery, we will gradually let them do things as they feel like they're able to. Most of the time, it's about a month or two that our patients are feeling like they want to go back and they're able to go back to their normal work activities. You may still have some soreness for a while. We avoid driving for a period of 4 to 6 weeks, more because if you had an accident or concern, there might be some degree where somebody might think that your surgery had something to do with it. We find that our reaction times after surgery come back usually within 2 to 4 weeks, but it's just a way of being safe. We want to keep our incision covered until it's completely healed, which is around 3 to 4 weeks to keep it covered. And if you do things outdoors, you want to keep it covered, that area covered for about 6 to 8 weeks. And then we work with all our patients to make sure we've got them going back to the levels of work that they're ready to. I'm one of several surgeons at our hospital that do very excellent joint replacement surgery. Brett Chris is one of our traumatologists who does hip replacement surgery. Mauricio Kafuri is a surgeon who does everything around the knee, including sports and reconstructive surgery. Dr. Agrawal and I are doing both hip and knee replacement surgery, and Dr. Andrea Vinsky manages patients with concerns related to cancer and also does joint replacement surgery as well. And just our team just operates under an umbrella of the Missouri Orthopedic Institute. We have wonderful people here that help take care of our patients. That includes our nursing staff, our physical therapists. We have radiology services, including MRI and CT scans that can be obtained in our building. We have a nutritionist who works with us to help our patients with specific dietary needs. We have physiatrists, as well as someone who can help if we have issues relating to mental health and how that impacts us with recover. And our physical therapists are very highly engaged and very interested in helping you recover as quickly as possible. As time goes on, there's always new things that are brought in. I talked a little bit about biological injections. We offer platelet-rich plasma here for patients who are interested in trying that. Stem cell therapies, as I said, those are things that are happening out in the community. We're certainly glad to answer questions that patients have if they come into our office, and you may have some questions here that I may be able to help with. I take intraoperative X-rays, or we also use a form of a portable X-ray called a fluoroscope or a C-arm. And that's just a way of confirming that what we've done in the operating room matches what we intended. This is a technologies with digital X-ray imaging that we didn't have 15 to 20 years ago. And so instead of an X-ray taking 15 or 20 minutes, we can have one in 30 seconds in the operating room. There are navigational tools that are being used. We probably will be working with robotic surgery platforms within the next 1 year to 2 years. We have had some patients who've had patient-specific joint replacement performed, where they get a CT scan and they get an implant that's designed specifically toward their bone structure. And that's also an option for patients. And just kind of in wrapping up, I said, we've had a good experience with our patients who have arthritis, and many of them managing pain for a number of years, if not completely without having any surgical intervention. We do engage surgical treatments for patients with severe arthritis who are very limited in what they're able to do. And we still have continually improving techniques for surgery. And I will say that the outcomes of surgery today, when we look at patient satisfaction, it used to be that we'd expect about 75% chance that somebody would be better from the surgery. Now, as I said, we're in the 90 to 95% range. And we expect that the implants, based on improvements in the materials over the past 15 to 20 years, are going to be lasting in the order of 25 to 30 years rather than 10 to 15 years, which is what people were told 20 years ago. We will continue to evaluate as we adopt new technologies, and that's one of the roles of us being here at a teaching hospital. And that's where I'm going to conclude at least my presentation. And I'm certainly willing and very eager to answer your questions.
Yeah, I will jump back in here. I know a few people joined us during the presentation, so I just want to remind everyone that if you have questions, you can use the Q&A button that you should see at the bottom of your screen, and you can type in your questions and we will get to those. But we've already had a few submitted, so we will jump right in. Dr. Keeney, someone is asking if you can speak to the treatment options for tendinitis or bursitis.
Yeah, so tendonitis, first of the thing is trying to figure out what's causing the tendonitis condition that you have. I think if it's something where you've overdone too much, the first step is to take a break from what you're doing that's irritating it. I get to speak to that. I have a tennis elbow right now, and I've given up going out and playing recreational golf for about 4 weeks to help make that better. That's first step. Second step is working on stretching around the area of the tendon, and also working on kind of a gradual process after that of re-engaging the muscles that are around the joint to try to help it. Anti-inflammatory medications and ice can help initially. Some of the tendons we can inject. We talk about pes and bursitis. That's an area where you can put an injection. It's a what's called a sheathed tendon, so there's a covering around it. And so when you put an injection, it's not going directly down to where the tendon attaches to the bone. And that can be effective for that particular problem. For pes bursitis, we do want to make sure we separated that diagnosis from a stress response or a stress fracture. So I might give one injection, but if the problem persists, then we're very likely to evaluate that with something like an MRI to just make sure we're not missing a different diagnosis.
Great. Well, we have another question here that has to do with pain medication. It sounds like someone is currently taking meloxicam and asking if it's appropriate to up their dosage. So I guess maybe a good question more generally is, when should you see a doctor for pain?
Yeah, no, I think we say, well, the first thing when we're talking about medications, often we address that with our primary physician. So the thing that I don't know about any given patient is how is your health, and what does an anti-inflammatory medication potentially do with you and for you, not just for your inflammation in your joints and tendons, but for your body. So anti-inflammatory medications for a small set of people can cause some issues with either the stomach or with kidneys. And so it's important, if you're on a medication like that, that you have a kidney function being checked about every 3 months to 6 months at the latest. I don't tend to recommend that people take more than the recommended prescription dose for a medication. We try to find an alternative to it if you're having to go from 15 milligrams of meloxicam to 30. What I would say is that so meloxicam and Celebrex are two medications that we typically use because of their safety profile more than it's because they're more effective as medications. So some people may find that they have better results taking Aleve or ibuprofen than they do taking meloxicam. So the first thing I would suggest is maybe try a different anti-inflammatory medication. And then the second thing is maybe see if there's something else going on that should be addressed.
Sounds good. Another question here, is there harm in waiting to have surgery? Does hip and knee pain something that typically gets worse?
Yeah. So I think there's a difference between when we talk about hurt and harm. I think, people who wait to have surgery may experience more discomfort or more pain. It's not necessarily going to be something that prevents them from having a good outcome when you do it. There are a few patients whose condition is so far advanced that going and having a delay in surgery can lead to structural damage around the joint. Typically, we will have a discussion with our patients to let them know if their condition would potentially put them at risk for that. And that's relatively uncommon. It's probably about 1 out of maybe 150 to 200 patients that I see. So I just want to let you know, if there's a delay, it's not that you're harming something. It's just that you may experience more discomfort. When we talk about decisions for joint replacement, part of what we take into account is your age. And again, if somebody's 50 years old, we expect a surgery may last 20 to 30 years. There's still a good chance that they'll outlive that surgery. For our patients who are closer to 70 years of age, the chances that you're going to outlive the surgery are decreasing. And that's not intended to be mean in the way I'm saying that. It actually means that joint replacement is a really good operation for you if you're at that age. And delaying the surgery doesn't necessarily help you once you get to a point where your joint is doing badly for you and you can't function well.
Okay. We have someone who's asking, they've had total knee replacement and a revision in the past. Does that qualify them, as they're currently having more issues? Could they be a patient, and what's the process? Do you need a referral?
Sure. Yeah, I think we're able to self-refer. So I mean, I'm glad to take a referral if somebody wanted to come in and see me. But also, if you said I'm having a problem, I just want somebody to see me, we would do that. Knee replacements, again, if you had a knee replacement put in the 1990s, the plastic materials that were used at that point in time were not as sturdy. And if a revision was done 10 or 15 years ago, is a chance there could be some issues that have happened with the parts that might be beneficial to be looked at.
All right. What are the initial symptoms you see when you may be a candidate for knee issues and complications? What should someone be looking out for?
So initial symptoms when people have a problem, if you're talking about arthritis, that it hurts. There are structures inside the joint that may also produce mechanical effects. So the meniscus or the shock absorber pad inside the knee and the labrum inside the hip can also be damaged, and they can be flipping in ways in the joint where they can cause locking or catching symptoms. So those are things I'd say. You also may see some stiffness develop in the joint where the motion of the joint isn't moving as it used to. So it's not uncommon for people to say, when I first get up, it feels a little bit stiff. If it's early morning stiffness, we do think occasionally about inflammation-based arthritis, like rheumatoid arthritis. And as it's something where as you get going and you do more things, it starts hurting more and more. That's typically what we see with wear and tear. The other thing I would say is when people first start having pain, sometimes you don't feel it when you're doing the thing you're doing. You actually will feel it at the end of the day. And that's not an uncommon thing that we hear from people when things first start. And then it just keeps progressing to the point where even it gets hard to start the activity.
Okay. Now, going back to, you were talking about tendonitis and bursitis earlier. Someone's asking, would steroids be the only option, or would PRP be an alternative as well?
Yeah, PRP is an alternative for patients with tendonitis. The questions that happen are more based on whether they're going to be covered by insurance carriers, and that's been the hard thing. But insurance has all changed kind of completely now. If I come in and see a doctor in January, I'm probably going to be paying for everything that comes in at the beginning of the year anyhow. If I get to December, then most of the time my deductible's been met, and then the insurance is covering those things. It gets into a longer discussion about why is it that PRP is not being maybe paid for up front. And I get to say we talked a little bit about the visco supplement injections, which I think are very useful for some of our patients. But after we've been using them for about 15 to 20 years, we had a publication that came from our National Academy called a clinical practice guideline, where they looked at the things that had been published on those treatments. And they said, they haven't shown that they're a whole lot better than alternatives. And we've had some publications that talked about the negative side effects of those injections in some circumstances. And then they said the weight of that didn't allow them to recommend them for treatment of arthritis, which is unfortunate because it was basically taking a weakness in the literature that we have on our publications in science and saying because there's a weakness in it, we're not going to allow treatment. But as soon as the insurance company saw that, they said, oh, we've been paying for this for 20 years and now you're saying it doesn't work. So when the next thing comes out, they're not going to just jump on and saying that, oh, we'll pay for that too. What we have, though, is pretty good evidence when we look at the current science on PRP is that it is effective both for treatment of tendonitis and tendinopathy and for, and tendinopathy means inflammation as well. But the other thing is it's good for that, and it's good for arthritis as well. And at least it's working as well or better than what those gel shots had been doing for arthritis. So hopefully over time, it's going to be something that the insurance carriers are going to say, okay, we've established that this works and we're willing to support the treatment.
Sure. And I do think it's important to point out as well that MU Healthcare has financial counseling available. We have folks that are dedicated to helping you figure out those insurance questions and financing as they come up.
Yeah.
Yep.
Go ahead. Keep going.
Well, another question is, how long after knee or hip surgery before I feel kind of back to normal? And are there activities that I should expect never to do again? Or is this something where I could really do everything I was doing before?
So I think that you're going to have two different approaches to that. 30 or 40 years ago, when people started doing surgery, they said, we have a surgery that we don't know how long it's going to last. And when they were first being developed, what they learned is that people were highly active on it damaged those prosthetic materials very quickly. So we're talking about surgery done between 1960 and 1980. And so the general guidelines that people were given was you can't do these things anymore. There is a little bit more of a relaxing approach to that as we've looked over time and seen how are these materials holding up today. So a couple of early studies that came out, one was out of Mayo Clinic with a particular type of the plastic used in the hip, and another one came out of Washington University where I was there, where we were looking at 10-year outcomes and looking at the actual wear of the materials used. And we weren't seeing measurable wear of the plastic materials, even in very highly active 50-year-olds and under. So where we used to tell people you can't, you shouldn't, you don't, where there's a little bit more openness to allowing people to do what they want to. Because part of the goal of surgery is to get you back to the life that you've had, not just to get you into the place where you are, the lower activity level. Now that said, it's not intended to give you a sports joint. So I'm 54 years old right now. If I said I want to be doing what I was doing when I was 30, that level of activity probably isn't going to be achieved, not because of the joint replacement, but just because my muscles and tendons are now 54 years old and they're not 30 years old. So it's not the joint replacement, but it's the other things that may make those activities a little harder than they used to be.
Along the lines of surgery, we talked a little bit about this idea of minimally invasive. What does that really mean for folks?
Yeah, I guess I don't like the term minimally. I said if I had coined it, I probably would have said something different, like less invasive. I think minimally makes it sound like there's no big deal. And I said as soon as a surgeon says I'm going to take a knife to your skin and I'm going to take a saw to your bone, there's nothing about that sounds like it's minimal. What I will say though is I said we've done a lot of things with enhanced pain control and enhanced recovery, and just speaking as a doctor who goes by and sees my patients after surgery. So when I was in training in 1993 to 1998, no one was comfortable after surgery. I mean, people were miserable in pain when we did the operations for the 3 to 5 days they were in the hospital. And I'm not saying that people are pain-free today, but what we're seeing is people are managing things a whole lot better. And where I would see somebody with a grimace on their face 25 years ago, today I'm seeing somebody reading the paper, watching the TV, eating dinner, doing the things that don't look like you're nearly as miserable as we used to be. And I think there's one of the things that had helped that a lot for us was the addition of an injection that we give around the joint that includes an anti-inflammatory medication and some other pain medication that helps to decrease the direct effects of pain from the surgery, at least for that first 6 to 8 hours while we get medicine on board.
Now, we talked a little bit about physical therapy after surgery. Um, is that necessary? And also along those lines, do you find that physical therapy can help before surgery as well?
Yeah, so what I would say is what I found is that patients who engage rehabilitation out of surgery come in with muscles that are in better condition. And also, I think just a knowledge of what they're going to be doing afterwards that decreases anxiety that goes along with having surgery. Um, if we talk about the timing of recovery, this is one of those things where people will recover a little bit faster from a hip than from a knee. And it has to do with the amount of swelling that occurs around the joint and just things where the joint around a knee wants to become stiffer as it heals, whereas a hip doesn't experience that so much. Most people who have a surgery will notice a difference in how they feel over the course of the first 4 to 6 weeks. There's a degree of discomfort that we have because of the trauma of having a surgery. I'm going to say trauma with a little bit of hesitancy. I said it's not the same thing as being in a car accident and breaking your leg, but it's a controlled process of creating an injury to make the body better. And so the body has to recover from that. So we'll see probably 70 to 80% of our patients by about 2 to 3 months are saying, yeah, I feel a whole lot better than I did. And then we have about another 15 to 20% of patients who over the course of the next 6 to 9 months will get better and better and better and again. And it's a hard thing because it's not always that I can feel it day to day, but it's more of a one day I woke up and I didn't quite remember when the last time was that I hurt. And that's hard when you're going through something at week 12 or week 16, whatever, 3 or 4 months out, and you're not quite there yet. But just be rest assured as to what we do see is by a year out, most people are doing much, much better by the time you get to that full year out. And I think it makes a difference about whether they did therapy ahead of time. Now, I will say the other thing is what about therapy after surgery? And I said, there's two ways of looking at that. One is, if we see how you're doing a year from now, did it make a difference if you're doing therapy at the beginning? Maybe not so much. The question is, how quickly did you get to where you were feeling better? And so it's not that you have to see therapy a bunch, but I think it's beneficial, particularly during the first 4 to 6 weeks, to be engaged with therapy. And it's more so for the knee and the hip. And it has to do with getting the mobility of the knee restored. And the other thing is, you may know a little bit more about yourself than we do. If I went to the gym, I would do better going with somebody else who would be helping me work on weight training than going by myself and doing weight training alone. So I think that you need to think about you personally and say, do I do better having a friend or a coach do this with me, or do I do okay if I do it by myself? And that's, I think, where it really makes a difference with therapy.
Great. We had a question that was pre-submitted, and I know we covered this during the presentation, but it sounds like there's been a lot of advances in this area, so let's cover it again. But how long are folks typically actually in the hospital after surgery?
Yeah, so if you do not have a medical condition that requires medical care, so if you don't have heart disease and you've had a heart attack before and had stents, or you have COPD, or a really challenging to control diabetes or something like that, most likely you're going to be going home within about 23 hours or less today. And I'd like to say, we like people staying this. We got a great hospital, and I love to keep my patients here for 2 or 3 days if we could do it. I think that process for our patients would be much better. What's happened over the last 10 years in an accelerated fashion in the last 2 to 3 years is that the people that I hate to say, but pay the bills, which means, you pay the insurance company and the insurance company pays the bills. But they've looked at this and said, we find out when people go home right away, they don't come back to the hospital and get readmitted. They do okay. And we've been sending people home after they have babies, and we've been sending people home after they have their knee ligament surgery and their shoulder tendon repair. Why is a joint replacement any different than those things? And so what's happened is they've kind of accelerated that process to a point now where pretty much everybody's being approved for an outpatient or a overnight stay at most. Because we have an inpatient care facility and we're not an outpatient surgery center, we bring our patients in and let them stay the night, because I think that's better for our patients to be able to have that experience and make sure they feel reasonably comfortable. We've had physical therapy, get a couple of sessions to work with them and make sure we've got them set to go in their home environment. And we got some pretty cool tools that they have here in the hospital to help people to feel comfortable getting in and out of their car and getting up and down steps and all those other things that I think are helpful.
Great. Well, I think that answers all of the questions that we've had. We have been recording this presentation, so you will get an email at a later date with this if you want to go back and refer to it or share with a friend or family member. I think we'll leave you with hopefully the website. There it is. You can request an appointment or get more information. Just visit muhealth.org/joint replacement. And thank you all for joining us today.